All right, Ninja Nerds, in this video we're going to talk about the abducens nerve, or cranial nerve 6. All right, so in this video we're going to discuss exactly where you can find the actual abducens nerve within the brainstem. Then we're going to talk about its course, where it's going, what structures it's moving around. Then we're going to talk about the structure that it's supplying, the function of that structure. And then we'll just have a brief little tidbit on clinical correlations. All right, ready? Here we go. So where would you find that nerve, or the sixth cranial nerve? Well, best way to look at it is like this. We're going to take a look at the lateral view now, because the lateral view makes it a little bit easier. All right, so let's go ahead and write this one here. So sixth cranial nerve nucleus is actually located within the pons. Okay, so the sixth cranial nerve nucleus is actually located within the pons. Now, there's another nucleus. It's actually called the facial nerve. You know the facial nerve, the seventh cranial nerve? There's actually what's called the facial nerve proper, which are the motor fibers. The motor fibers actually move behind the sixth cranial nerve nucleus. They move behind the sixth cranial nerve, and then they come outwards and out a little bit more laterally, okay? The sixth cranial nerve is actually going to be running right. So, you know, whenever it moves back here, the axons here, they produce a little depression here. So they produce a tiny little depression here. This tiny little depression in the fourth ventricle, because you see this cavity right here in the back of the pons and the medulla, this is actually a fluid-filled cavity filled with cerebrospinal fluid. This is actually called the fourth ventricle. It's actually connected with the cerebroaqueduct and then with the foramen magendi and the foramen luschka. What happens is the seventh cranial nerve wraps around the sixth nerve nucleus and produces a little depression in the back there. That little depression is called the facial colliculus. The sixth nerve is located at the level of that little depression within the fourth ventricle, called the facial colliculus. And then what happens is it moves downwards and then out at that pons medulla junction. But to see it a little bit better with relationship to the seventh nerve and even another nerve called the eighth nerve, vestibulocochlear nerve, I want to look at it from the anterior view. So now, let's say here, coming out here, so let's say here's your midline. Here's the midline, okay? Right here, the sixth cranial nerve is going to come out like this. So that's the sixth cranial nerve there, that's the sixth cranial nerve there, okay? So this would be sixth cranial nerve here, and this would be sixth cranial nerve right there. On the sides of it, what nerve do you think is going to be coming out right here? This is going to be the seventh cranial nerve, and it's made up of the facial nerve proper and the nervus intermedius, which is a whole bunch of other different types of fibers, right? But it's going to move like this. And then on the sides of that, if we do this one in green, you're actually going to have another nerve here, which is called the vestibulocochlear nerve. And the vestibulocochlear nerve is cranial nerve 8. So you're going to see these right along the pons medulla junction. But how would you say that the sixth nerve nucleus is coming out? Okay, so we know it's at the level of the facial colliculus, which is that little depression in the fourth ventricle caused by the facial nerve. And we know it comes out at the pons medulla junction medial to the what? Facial nerve. And outward more than that is going to be the vestibulocochlear nerve. All right, sweet deal. So we know it comes out at the pons medulla junction. All right. So it's coming out here at the pons medulla junction. So let's get rid of this facial nerve because we don't want to confuse it with another structure that we're going to talk about. Now, running right near this is going to be an important blood vessel. So there's actually going to be an important blood vessel right here, running right near this area here. And this blood vessel is called the anterior inferior cerebellar artery. Okay, so it's the anterior inferior cerebellar arteries. Now, a little bit above it, there's actually going to be some pontine branches here, which are branches of the basilar artery. So here, let me show you what I'm talking about here. Let's come down here for just a second here, and let me show you what I mean here. Let me draw another cross section real quick. So if I draw another cross section here is the midbrain. Let's come back there, and then like this, pons, medulla, and then spinal cord, right? Okay, a little bit of a tilt there, but nonetheless. What happens is their vertebral arteries come up through the transverse foramina, right, of the cervical vertebrae come together and make the basilar artery. Then as they move up, they give off a posterior cerebral artery. Then they go up off a superior cerebellar artery. Down here, you're going to have another one, which is called the anterior inferior cerebellar artery. And then over here, there's actually going to be some pontine branches. Right here, that sixth cranial nerve is actually running in between these guys. So it's running kind of right below these pontine branches and just above the anterior inferior cerebellar arteries. Okay? And that's relevant because if there's some type of situation in which those actual vessels could be having an aneurysm or having some type of situation that could be compressing this nerve for whatever reason, some type of malformation, that could cause some type of sixth nerve palsy. All right, cool. So now, these fibers here, oh, that was cool. These fibers move out, and when they move out, they move up this actual part of this actual bone here. You know, this is the posterior cranial fossa. As they move up this posterior cranial fossa, there's actually a little part here called the clivus. It's actually called the clivus. So if you imagine here, let's say I'm posterior cranial fossa, then I go into the middle cranial fossa, and then anterior cranial fossa. As I'm moving up this way, this is called the clivus. And then it goes over to the petrous part of the temporal bone. So once it goes over here, it's at the petrous part of the temporal bone. This nerve is climbing up the clivus. Then it goes over to the petrous part of the temporal bone. And it moves and pierces in between a tiny little canal. There's actually a tiny canal here that it moves in between. And another structure actually runs right with it. There's actually a vein that actually runs with this in this sinus here. There's a vein here that also runs within that area. So it pierces through this little area here, and that little hole that it actually moves through into this canal, it moves into a little canal called Dorello's canal. So right now, these two structures are in a canal, and that canal is called Dorello's canal. So what canal are they in right now? They're in a canal called Dorello's canal. And there's two things in there. One is going to be what's called the inferior petrosal sinus, which is basically a dural sinus. And the other one is going to be cranial nerve 6. All right, the abducens nerve. Now what happens is, runs up the clivus, pierces that little actual meningeal layer and goes into the Dorello's canal. Then from there, it's going to run with the inferior petrosal sinus. It's going to come out and it's going to move into, what is this structure here? So what is this structure here called that it moves into? It moves into this, and this structure here is called the cavernous sinus. So it's called the cavernous sinus. Now the cavernous sinus is actually a dural sinus. Why is that important? Because if you remember here, there's actually this brown tissue, like the dura mater here. You see this brown part here? This is actually called the periosteal layer of the dura mater. All right, periosteal layer. Then this maroon layer here is the meningeal layer. So this maroon one is called the meningeal layer of the dura mater. When these break away, right in there is that dural sinus, right? And this is going to be the cavernous sinus. Another way to kind of look at this is like this. Let's say I draw here the sella turcica of the sphenoid bone, and here's where the pituitary gland sits. And then right here on the sides, you're going to have this little dural sinus, right? And this little dural sinus here is going to be called the cavernous sinus. Now, what do we say actually runs right up through this area? If you guys remember from the oculomotor nerve and the trochlear nerve video, we said it was the internal carotid artery. It was running in through the cavity of the cavernous sinus, running through the cavity. And then if you guys remember, we said that on the wall over here, there was a tiny little wall on the lateral sides over here, and there was some actual nerves running through there. Just to be consistent here, we said that it was going to be third cranial nerve, fourth cranial nerve, ophthalmic division of the trigeminal nerve, and the maxillary division of the trigeminal nerve. Same thing over here, 3, 4, V1, V2. The sixth cranial nerve is running within the cavity. So the sixth cranial nerve is running within the cavity of the cavernous sinus, just so that we're clear. Okay, so it runs through the cavity, and then as it's running through the cavity, again, what structure would actually be right here? If I put a little hole here in the skull, this would be the foramen lacerum here. And then there was another one over here, which is called the carotid canal. You know there's going to be the internal carotid artery running through the carotid canal. Then it's going to come upwards through the foramen lacerum and run through the cavernous sinus right here, right? And this is called the internal carotid artery. Okay, the sixth cranial nerve is running right next to it, right? So right next to it. And then it's going to come where? It's going to come out of the cavity and it's going to go into a hole here in the skull called the superior orbital fissure. So it moves through this hole here called the superior orbital fissure. Okay? Now, what happens from here? It's going to come from the superior orbital fissure, it's going to go into the orbital cavity. And from the orbital cavity, it's going to supply one main muscle. If you guys remember that little acronym we said, LR6, lateral rectus, sixth cranial nerve. And if you guys just want a little reminder, SO4, superior oblique, fourth cranial nerve. And then all the rest, or all the frickin' rest, is going to be 3, right? So all the rest are going to be supplied by third cranial nerve, oculomotor nerve. So this guy's going to come out of the superior orbital fissure into the orbital cavity and supply this muscle right here. So again, if you imagine, we're looking at this from the lateral side. So if you're looking at it, imagine I took the actual temporal or zygomatic part of the orbital cavity off, and all we're seeing is the nasal part. Okay? So this right here is the lateral rectus, that muscle. When this guy innervates the lateral rectus contracts. And what does he do? You know the lateral rectus actually causes abduction of the eye. So what's the function of this lateral rectus then? Well, it's actually going to pull the eyeball outwards. So the lateral rectus does what's called lateral rotation. So it does what's called lateral rotation. Sometimes you might even see it written as what's called abduction of eye. Maybe another reason why they call the nerve that supplies it the abducens nerve, because it's going to cause the eye to abduct. In other words, pull the eyeball, what? Like this. It's going to come outward, okay? So that abduction is my right eye. Look for the right eye. I'm pulling the eyeball outward. That's the job of the abducens nerve, and the muscle that's doing that is going to be the lateral rectus. I'm doing that right there, okay? That's the lateral rectus. Now, again, seeing it from this lateral view doesn't do justice to how the nerve is actually coming into the orbital cavity. So let's look at it from the anterior view. So remember, I'm taking my eye and I'm looking at this in the back of the orbital cavity. And this is what we see. If you guys remember, it's always good to recap. That's the way that we remember things, is going to be what's called the annulus of Zinn, or remember, you can call it the common tendinous ring. And remember, that's the origin for all of these different types of extraocular muscles, which are going to be inferior rectus, lateral rectus, and again, this would be temporal or your zygomatic side over here. And then over here is actually going to be the nasal. And then again, this is the roof, this would be the floor, and this would be the posterior wall. Annulus of Zinn here, origin of the lateral rectus, inferior rectus, medial rectus, and superior rectus. And if you guys want to remember, we had the levator palpebra superioris, which basically was going to elevate the palpebra. We talked about the oculomotor nerve, and if it's damaged, it can actually cause the eye to droop. There could be ptosis of the eye, right? And then this one over here, which is the superior oblique. Okay, so what happens is this sixth cranial nerve, I'm going to change his color for just a second. He's going to move inside of the common tendinous ring. If you guys remember what we're actually coming right here, we had the superior branch of the oculomotor nerve. We had the inferior branch of the oculomotor nerve, and then what was smack dab there in the center? The nasociliary nerve. And then over here was the lacrimal nerve, frontal nerve, and trochlear nerve, or cranial nerve 4. The sixth nerve is running inside of the common tendinous ring, that part of the superior orbital fissure. And then it comes out here and supplies the lateral rectus. That's simple. And then it causes lateral rotation, or you can also say abduction of the eye. Okay, so that covers that part. Now what I want to do is, so what have we talked about so far, guys? We have hit origin of the nerve. We talked about course of the nerve. We talked about the structures it supplies. Now let's do a tidbit on the clinical correlations. All right, one thing is, same thing. If there is any type of, there could be so many things. You could have some type of tumor that develops in here. So maybe a tumor that's actually compressing the sixth cranial nerve. Maybe the blood vessels that are supplying the sixth cranial nerve become occluded or infarcted. So some type of infarction of this area. Maybe an abscess Okay, so due to some type of infection, maybe an abscess develops in this area and the person has this compressing that area there. Or maybe multiple sclerosis, which demyelinates the axons of the CNS, right? So whatever the situation might be, maybe they have multiple sclerosis or an abscess or an infarction or a tumor, whatever it might be, it could be affecting the nucleus of the sixth cranial nerve. Also, what if it comes out of this area and there is some type of situation, maybe vasculitis, like inflammation of the anterior inferior cerebellar arteries, and it's actually compressing this sixth cranial nerve. If it's compressing the sixth cranial nerve, that could also cause a problem. So some type of vasculitic lesions of this anterior inferior cerebellar artery, or maybe even, less commonly, maybe an aneurysm that's compressing it also, okay? Another thing, you see where it runs up the clivus, right? So really, I could actually even kind of show it like this to make it even more perfect, it kind of comes here and then comes upwards, right? What happens is, let's say that for whatever reason, you get conked in the head and you develop a hematoma within some part of the meninges, and you develop high intracranial pressure. What happens is, when you have high intracranial pressure, what it tries to do is it tries to herniate the brainstem out of the foramen magnum. It tries to squish this part of the brainstem outwards. As it does that, it can pull on the sixth cranial nerve. So imagine me trying to pull this sucker out of the foramen magnum. I'm pulling on the nerve, and it can just keep bashing that bad boy against this bony part of the petrous part of the temporal bone. If it keeps banging it against that, you could actually develop some type of sixth nerve palsy. So maybe some type of high intracranial pressure could also cause the abducens nerve to be banged up against that bony part of the petrous component of the temporal bone. Same thing, we talked about this within the third nerve and in the fourth nerve, if there's some type of aneurysm. And this would be definitely super affected here. If there's some type of aneurysm, this could affect the abducens nerve, or if there's some type of infection that develops within the cavernous sinus that thromboses the internal carotid artery, or if there's a fistula. Sometimes you can develop fistulas in this area, and that could also compress the sixth cranial nerve. And the last thing is maybe some type of situation in which there's actually trauma. Maybe there was some type of trauma to the individual, and because of that, it damaged or fractured some of the bones here, and actually maybe it compressed the nerve or sever the nerve in some type of way, right? Now, if that happens, how will the person present? Okay, well, the lateral rectus can't contract. What's the main function of the lateral rectus? He pulls the eyeball outward. If that's not working, where's the eyeball going to want to go? Whoop, right to the middle. And now he's going to be looking like this if it's real bad, right? One of the eyes. So what's going to happen now? This eyeball, let's say that the right abducens nerve is damaged. If the right abducens nerve is damaged, now this eye is going to be like this. Okay? So it's going to be inward now. And you know what they call this when the eye is actually inwards? This is called unilateral. Okay, so this would be the right side, or unilateral internal strabismus. Now, the reason why I say this is because if you have this person like this, that's at rest, that's at their normal straight staring gaze. Let's say you're like, I'm going to freck them up a little bit. I'm going to have them turn their eyes to the right. So now I'm going to have them turn both of their gaze, I'm going to have them turn their gaze to the right. If I try to have this guy turn his gaze to the right and this guy turn his gaze to the right, what's going to happen? This lateral rectus is not going to contract. That sucker isn't moving, it's going to stay there. This guy's medial rectus, everything is functioning over here. So its medial rectus over here is going to contract, and it's going to pull the eye inwards like this. Now what's going to happen? Because of at rest, just even their straight gaze, this eye is going to be kind of leaning this way, right? And this eye could be standing straight. So because of that, their visual fields are all thrown out of whack. So they can develop what's called diplopia. Okay? And this is basically double vision. Okay, so they can develop double vision. And again, you could make it even worse if you want to be, crude and rude, and you have them turn their actual gaze to the paralytic side. So if the right eye is paralytic, you have them turn it to the right side. This eye will move that way. The medial rectus will contract. This lateral rectus will not contract, so it'll stay there, and they'll have bilateral internal strabismus. And it'll be even worse. The diplopia will be even worse. Okay? All right, engineers, so in this video we covered a decent amount of information about the abducens nerve. We talked about the origin of the nerve, the course of the nerve, the structures that it supplies, and just a little tidbits on the clinical correlations of it. Guys, I hope all of this made sense. I hope you guys did enjoy it. If you guys did, please hit the like button, comment down in the comment section, and please subscribe. As always, Ninja Nerds, until next time.